Hello, everyone. Thank you for coming in. We're going to start the session. This is the exposure-related lung disease, sick and fine. And kind of one of the endpoints of this session is to make emphasis and review with you the importance of the exposure assessment, kind of a little bit in the context of hypersensitivity pneumonitis. I have no specific disclosures. We don't want to be talking specifically about any specific treatment. But I like to go over these questions with you. If you have the app in your iPhone, in your smartphone, just go for it. See how you do. So let's warm up a little bit with this question. So it goes like this. In the diagnostic approach of hypersensitivity pneumonitis, which of the following is correct? A, the social, occupational, environmental history is negative, thus the antigen exposure is cryptogenic. B, lack of clinical improvement with antigen avoidance rules out the diagnosis of hypersensitivity pneumonitis. C, a identified persistent exposure is common in fibrotic cases and can alter the course of the disease. Or D, if you suspect hypersensitivity pneumonitis, serum antigen-specific IgG testing can help you confirm the diagnosis. So let's take 20 seconds. Perfect. So the right answer is C, so let's go one by one. A, the reason I put this question in is because it's important to remember that if you are unable to identify that exposure, it does not mean necessarily that the cause or the clinical course of the disease is idiopathic. Regarding B, this may apply mostly to patients with non-fibrotic disease. Lack of clinical improvement might not be seen in patients who have multiple exposures or who have advanced lung disease. Regarding C, a good example probably are those patients who have bird-related HP. That is good amount of data, especially coming from Japan, pointing out that if you remove the bird, that might not be enough because the antigen might persist for weeks and months. And regarding D, the serum antigen-specific IgG testing is not a confirmatory test. So the role of this type of test in the diagnostic algorithm in hypersensitivity pneumonitis is a little bit questionable. So this takes me to this next slide that I'd like to share with you because to go over a potential misconception here, and is that of not knowing the exposure. So a few years ago, we showed that it appears that if we are not able to precisely identify the exposure in patients with chronic disease, that subset of individuals may be at higher risk to develop disease progression, and they appear to have a much worse prognosis. And this study and many others in the literature now are quoted, and I think this has led to the rise of a monster as evidence of the so-called idiopathic hypersensitivity pneumonitis. And so I think it's important to remember, and you will see this in the literature, that frequently retrospective cohort studies kind of outline the frequency of not knowing that exposure. But you need to understand that if you carefully look at the methodology of every study published up to this day, you will see that none of the studies have detailed precisely the MDD process for a confident or a working diagnosis of hypersensitivity pneumonitis in the context of not knowing the exposure. So that's important to remember. So I think to make more emphasis in this concept is the fact that hypersensitivity pneumonitis is an antigen-specific disease. Remember I think it's important to kind of highlight the definition of hypersensitivity pneumonitis. It's a immune initially initiated immunological lung disease, which is complex, which is triggered by a large variety of antigens, to which a genetically susceptible individual has been previously sensitized. And so the type of exposure, the genetic background of the person, and the lung microenvironment will initially kind of dictate and determine that adaptive immune response early on, and the patient in the top may have a pro-immune response and may have more inflammation, and as I said, may go into developing pulmonary fibrosis, while a large group of patients may have just the alveolitis and the disease may resolve. And so also under the microscope, it's important to remember that hypersensitivity pneumonitis is a T-cell mediated lung disease, at least early on. And you will see T cells in the alveolar walls. You may see them all in the peribronchiovascular area in response to the antigen-presenting cell. And so, in contrast to sarcoidosis, the nature of the inciting antigen is not in question here. In contrast, for example, to a rheumatologic disorder, you may see T cells, but this is not a B cell predominant disease. You will not see many germinal centers or pleuritis. So this doesn't happen just out of nowhere, okay? And probably the best example is the immune host response of the individual to that antigen. And we recognize that on histopathology based on the presence of the loosely cluster of histiocytes and macrophages forming granulomas. If the patient presents to you, as in many cases will be the case, advanced with evidence of airway center fibrosis and subpleural fibrosis, it's not uncommon that the type of onset for pulmonary fibrosis from that exposure is quite prolonged. And the importance here is that you have to spend time trying to look for that exposure that has happened many years ago. Because in many cases, that exposure goes unrecognized, or the exposure assessment is a work in progress. I don't like to categorize the disease as cryptogenic or based on a colorful name like farmer's lawn. I like to kind of use some degree of likelihood. Either the patient has a known identifiable exposure, or is indeterminate, or is unknown yet to be identified. And so HP can present as many cases of their causes, and perhaps more than any other lung disease, with the exception of probably pneumoconiosis. To make a confident diagnosis of hypersensitivity pneumonitis, you really have to put your detective hat on, because it requires a very detailed history. And this became evident in the recent International Modified Delphi survey, as you may all recall, where many pulmonologists around the world were enlisted, and by consensus, the diagnostic item that was more valuable was that of the history of an environmental exposure known to cause hypersensitivity pneumonitis and also temporality. Now, characterizing that exposure early on, of course, as I showed you with that first slide, can help you kind of get a sense of prognosis, and probably will help you with treatment, but it's also imperative that you characterize that exposure for the diagnosis. And so there are three main domains that you need to try to make a confident diagnosis of hypersensitivity pneumonitis. Of course, the most important one is the history, as you can see here, and probably the antigen-specific testing, but it seems that this may be more valuable as an exposure assessment tool. You need the imaging and you need the bronchoscopy. If these three domains are satisfied, that person likely has hypersensitivity pneumonitis. If that person only has one of those domains, you fall into this intermediate area and you will need more testing. Now, when I talk about history, what I mean is the integration of the geographic location where you practice, the clinical context of that presentation, and of course, the environmental and occupational history to try to establish that pre-test likelihood of hypersensitivity pneumonitis. If you take, for example, the frequency of that patient presenting to your practice, the epidemiology of the disease, I can tell you that at least here in the US, the frequency of cases that will present to your practice increases exponentially with age. So like IPF, hypersensitivity to pneumonitis, is a disease of aging. At least half of the patient that you may see in your practice will have evidence of chronicity, and probably at least, I can bet you, a third of them will have evidence of fibrosis on imaging. So if you integrate this with the clinical context and the history, that will help you determine the predictive value of any test that you will do after that. It could be the CT of the chest or the bronchoscopy. This is why the history is so important. So when I try to characterize the history of the exposure history of any patient, there's 5 components I like to kind of think about that I unify in my head. One is I try to do some sort of visual reconstruction of the presentation, and in many cases I might ask the patient, can you draw to me your workflow and where you spend time and the tasks that you do? I commonly use Google Maps. Of course, I'll ask the patient if he or she will allow me to do that. And if they have photos of the potential source, even better. Because we all are short in time and we have to see many patients, and because of recall bias, there's a few things that I like to do. Number one, remember that a bird is commonly not considered to be a pet, and is in the 3rd or 4th visit that the patient will tell you, oh yeah, I have a bird. But I like to engage the family and the caregiver early on in the discussion of the exposure assessment. You need to bring them for reevaluation and for reassessment if you think you haven't finished quite well your exposure history. And please use a questionnaire, because I think that will help maximize the patient recall. If you suspect a sentinel event at work, or the patient is talking to you about exposure at work, the first thing you need to think and the first thing you need to do is you're going to go ahead and refer that patient to an occupational medicine specialist. That's number one. In the meantime, there's a few things that I have done in the past. One is there's, in this era of the internet, you have access to many freely available databases, and I'm showing some of them here, where you can access those databases if the patient brings you that data safety sheet, which is commonly a prolonged list of chemicals and materials, and you can kind of connect the dots and see if that lung disease somehow is connected to that exposure that the patient is describing to you. And probably the most important part here is using features of causation. This is what makes an exposure relevant. And it's not just one, it's all of them. So we think all the time about temporality, but if you have all of those, that will make that exposure relevant, especially if you are unable to disprove causality. So for example, if your patient has CHF or COPD or asthma and is presenting with an HB-like presentation, that may disprove probably the causation that you're looking for of an exposure causing the disease. And lastly, it's important also to understand the other things and the other behaviors that the patient is involved to, such as hobbies. Now, going more into what do we look into the questionnaire, any questionnaire out there has 3 components: the environmental history, the work history, and the exposure history. And you can find one of these questionnaires in the CHEST ACCP website. Many hospitals have them online and you can use them. One of the things that I have recently observed is this has become kind of a usual complaint about not being able to identify the inciting antigens because we don't have a validated questionnaire across all practices. And the problem in reality is not using a questionnaire in the first place, because you need to remember that a questionnaire will not quantify necessarily the exposure for you and will not establish causation. It is you, at the end of the day, with your sound clinical judgment, that will do that. So if the patient answered yes to one or more questions, you need to dig in more and characterize the circumstances of that exposure. So this is an example of a non-occupational environmental history taken from our questionnaire, a national UISH commonly. The goal of this part is intended to characterize the home exposure. And if there is anything in the house that can explain the disease. So how is the home? I'd like to ask the patient how many homes that he or she may have, or cabins, where the patient has lived before. And also understanding the water supply, the heating and cooling system, any dust reservoirs like carpets, and the condition of humidifiers and dehumidifiers, and how close is the home to an industry or a waste site. This is where Google Maps or that toxnet.gov that I show you has maps and can kind of help you visualize that issue. Most of the environmental questionnaires are out there have a permutation of about 4 or 5 questions that try to get to this issue, and of kind of, do we have to do a mold and dampness assessment in that home that have to be remediated? And there are 5 questions that appears to be quite sensitive. The first one is, do you see any evidence of mold mildew? Number 2, do you smell mold mildew? Number 3, obviously, if you see condensation in the windows, well, the humidity is probably too high. Number 4, there is any evidence of dampness indoors because there is a leak or a broken pipe or flooding. And lastly, if there is any concrete evidence of water damage in the house, indoors, or from water intrusion from the outside. So if the patient answered to yes to all those questions, there is a big problem. In terms of the occupational history, there's a few questions I like to ask the patient, which I think they're quite sensitive. One is, what do you do? How do you do it? Are you concerned about an exposure on and or off work? Are you concerned about an exposure that your coworker may be exposed to? Are you satisfied with your work? Do you use any protective equipment? And are you exposed to vapor gas, dust, and fumes? I find those questions very, very sensitive. That said, the questionnaire, again, is going to be very helpful to organize your thoughts. And commonly, this is how it looks. In one of the columns, you ask the patient to put all the jobs that they have, no matter how minor they are. And also, it's important to remember to outline any military service because of the deployment lung disease. You have the dates, you have the description, and what kind of is the responsibilities of that person in that work. You may see in some questionnaires a list of chemicals and components, and that can also help patient recall about a potential exposure at work. Some questionnaires may include an exposure inventory. If the work history that I show you is like the medical history, this is more like the review of systems. And so any yes answer here will alert you that you have to, again, stop and ask more questions to try to characterize that exposure. So let me jump in briefly here about the serology in hypersensitivity pneumonitis, which is very commonly done. So IgG precipitins refers to a qualitative test, and Antigen-Specific Antibodies is a quantitative test. With the first one, the IgG precipitins, you're using double diffusion. Commonly, that's the most common method. And the problem with this method is that even though it's inexpensive, simple to use, is not really reproducible, and it's associated with a lot of false negative. Now, the quantitative test, where you measure the antibody, of course, is more sensitive, but you have to set off a cutoff, and because it's more sensitive, it's associated with more false positive. Of all the methods that are utilized, ELISA is the most common one. Now, there are many issues with serologic testing the diagnostic algorithm of hypersensitivity pneumonitis, and I won't be able to go through every study out there, but let me try to summarize some of the problems. Number one is that many of the studies describe these tests in patients with high pretest likelihood. So the test result will not change my mind against or for hypersensitivity pneumonitis. In many of the studies, the clinical context is all lumped together, and or you might not be able to determine what method they utilize and characterize that as either positive or negative precipitants. And probably the most common seen out there is that many of the studies use a case control design, which can enhance the test characteristics of the test because the investigator is artificially setting the prevalence of the disease at 50% at two extremes. And the last one that you probably have heard a lot is that this is a marker of exposure. It will not tell you when the exposure happened, and it will not help you differentiate healthy exposed individuals from those who are exposed and have the disease. This is a good example of a study done in Italy in one center, 108 patients with ILD. They look at the at the high-resolution CT chest, and the radiologist establishes his level of confidence. Then they look at the exposure, and then they look at the precipitins, and they then went on to see how the precipitins was helpful to see how helpful it was in trying to characterize the diagnosis that was done by MDD. And so if you can see here, there were about 18 patients that were diagnosed by MDD with hypersensitivity pneumonitis. About half of them have negative precipitins, so very high false negative rate. But here's the issue. And so you can see that 12 patients, about half of them had positive precipitins and had an exposure. But look at this. They had a CT that was characteristic, and they have an exposure that was compelling. So in that group of patients, I already know that I'm above my treatment threshold. I already rule in the disease. So the precipitin testing in this case will not make it more confident that they already have hypersensitivity pneumonitis. Now, if you flip the point, this is a very interesting study published a few years ago in 19 subjects with hypersensitivity pneumonitis, looking into probably the value of these tests in exposure assessment. And so what they did is they took the serum of those patients and they tested against environmental samples from the home and the workplace, and also against a standard HB panel. And what they found was that when they did immunodiffusion testing from those environmental samples, there was no correlation between the standard HB panel and the testing that they did at their lab using the environmental samples. 31% of them had a positive result to that environmental sample, while 63% of them were positive for that standard HB panel. And only one patient had a positive mole all across the board. So there was no good correlation. However, what they found was that the patient-centered exposure assessment was really helpful. And so I don't think they were expecting they were not really necessarily looking for that aim. But what happened is that in patients who had multiple antigens, they commonly came from one source. So they were able to identify that source in the home or the workplace. The other thing that they noticed is that in many cases, that bulk sample that they took from the home and the workplace was positive while it was negative in the HB panel. So again, it helped them kind of rethink about the likelihood of the exposure. So in some cases, home inspection may be valuable. So let me try to summarize briefly here what I've been trying to tell you. So number one, if the exposure remains unidentified, it does not mean that the disease is idiopathic. Remember to try to characterize exposure based on likelihood. Please use a structured questionnaire that is relevant to your practice. It will help you save time and help the patient recall. Please use features of causal inference when you try to look at an association between the exposure and the disease. And remember that it is characterizing that exposure and the clinical context that will help you determine the predictive value of any diagnostic test that you will do after that. And lastly, the IgG-specific testing might be most informative if the antigens are taken from the patient environment. However, it's important to remember that this requires a lot of expertise. It can be costly and is not widely available for everyone, at least here in the US. So I will stop here. Thank you for your attention. And I'd like to invite Dr. Weissman to come to the podium, and we can probably take questions at the end for the sake of time.